Good evening, everyone. How are you all? So welcome to First Aid AMC MCQ free 2-week sessions again. So tonight we're going to finish cardiology. I hope our last session was all right for you. I hope you learned about how we take our sessions. And also, I hope that you are liking our sessions. That's what we want to know. So, and also back to back, you are getting some classes. There was a class yesterday with Dr. Aruj. If you are not aware that Dr. Aruj is one of the best mentor we have come across throughout these 8 years. She recently passed her clinical exam, and she also did our first aid AMC clinical course, and she passed within like 4 or 5 months. So she is a brilliant mentor, and I'm sure under her mentorship you will do really good, especially with the question solve. So tell me about are you guys enjoying our session so far? Do you think we are going with the right pace and everything? You are not struggling? Brilliant. So let's start our cardiology session 2. Cardiology session 2 focus on all other aspects of cardiovascular system, including mainly we are focusing on heart failure. We are focusing on hypertension, valvular heart disease. Those will be our main topics today, and few other random topics. So for cardiology, there will be another session with the course student also, which we are going to cover mainly the palpitation chapter and the ECG, because those two goes together. Apart from that, everything else we will finish tonight. And we will do a cardiology question solve session after this theory to give you some idea that how questions can come in the exam, and you can easily come to the answer if you have a good theory knowledge. And also remember that the course classes are going on. You are actually doing our course classes. This 2 weeks free session is part of the actual course. So after this 2 week session is over, we will continue with the full rhythm. There will be no break in between. So if you are liking the session, I would always suggest that after this 1 week, you know how we take the sessions. So I would suggest that go and start the course subscription so that you can continue with us smoothly. Okay, moving on to cardiology theory session 2. So you remember this video that we have shown you last time, that how the cardiac system works. Now, if we go through it again a little bit. So just watch the video. So you can see the systole and diastole, right? Like every beat that you see. So this is contraction and relaxation. So the contraction is called systole, and the relaxation is what we call diastole. So when a heart does not function properly, this contraction will not work sometimes, or sometimes the relaxation will not work. Now you can see that when heart needs to work harder, like let's say someone has got ischemic heart disease, their heart muscle becomes it doesn't remain that strong anymore. So it can't push the blood as it should be. So what it does that to compensate that weakness, it starts to become hypertrophied. So the left ventricle, see that left ventricular wall, how much hypertrophied it has become. So it starts to become hypertrophied, and that is what we call left ventricular hypertrophy. And at one time, as the muscle grows bigger and bigger, at one time it loses its elasticity and it fails. So it's trying its hard to do everything. Okay. Now let's watch with the sound.
Heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
All right, let me open my screen back again. So now you can understand that we are going to discuss the congestive cardiac failure today. So congestive cardiac failure is really an important topic. Now you understand how the cardiac system works, and to give you the pathophysiology of different symptoms that we see in a cardiac failure patient, you need to understand the basic. Without basic, you will always just memorize things. Now, if you remember, in our last session, we discussed how things works, and this will be important for your heart failure understanding as well. So blood from superior vena cava and the inferior vena cava will come to our right atrium. The blood then goes through the tricuspid valve into the right ventricle, and then through the right ventricle, blood will go to the lungs, and this is the pulmonary valve, right? Now, all of these bloods are deoxygenated blood coming from all over the body. Through the pulmonary artery, this deoxygenated blood will then go to the lungs, and in the lungs, this will become oxygenated. And you remember how this becomes oxygenated. We discussed that in our last session. Once this is oxygenated, this oxygenated blood will be carried into the left atrium by the pulmonary vein. And then through the mitral valve, blood will go into the left ventricle. Now, through the left ventricle, blood goes to the whole body by the aorta, right? And that's our aortic valve here. So this is the basic pathophysiology of how our heart normally works. Now, if there is a problem in this normal function, then we call it heart failure. So what happens in here that, as you have seen in the video just a few minutes ago, that if the heart starts to get failed, could be due to a lot of reasons, could be excessive high blood pressure, patient can have valvular heart disease, patient can have a MI or ISD, like ischemic heart disease, which can make it weak. And because of that, heart muscle starts to become hypertrophic, and eventually it becomes left heart failure. What happens when there is left heart failure? So if there is a left heart failure, the heart will not be able to pump the blood into the aorta anymore. So if heart is not able to pump the blood will start to accumulate in this chamber. Once it becomes more and more accumulated, it will then go back, right? Just like a pipe, how the pipe system works. If something is blocked, then it goes backwards. So it starts to go backwards, which means that then the left atrium starts to become full. At once, left atrium will become full with fluid and blood. Then it will go back through the pulmonary vein. Then this fluid or blood, it will now stay in the lung because there is lots of blood in here. The lung will not be able to send more blood in here. So it will start to accumulate fluid in the lungs. When lung starts to accumulate fluid, what we call it? We call it pulmonary edema. And that is the commonest presentation for heart failure patient. So they come to us with acute pulmonary edema due to left heart failure. And this is how it works. Does it make sense so far for everyone? Everyone is good? Very, very good. Now, when there is pulmonary edema, that means more and more fluid is accumulating in the lungs. So then at once, the lung will become overloaded. Then it starts to send, or the fluid starts to become accumulated and it goes more backflow. So the pulmonary artery then starts to become overloaded. When pulmonary artery becomes overloaded, we call it pulmonary hypertension. Now, think about that this pulmonary artery has got a lot of pressure now. Against this excess pressure, the right ventricle needs to push blood. So right ventricle then needs to work hard because now there is more pressure in pulmonary artery. So right ventricle needs to become more strong to push the blood there. So the right ventricle starts to become hypertrophied. So that's right ventricular hypertrophy. At once, right ventricle will no longer be able to do it, so it will become failed. So that becomes right heart failure. So what is the commonest cause of right heart failure? The commonest cause of right heart failure is left heart failure, because that's how it all starts. Now, once right heart failure happens, means that there is more and more fluid in the right ventricle, which now then go back, which means now in the right atrium there is more and more fluid or blood. The problem is that now from the superior vena cava and inferior vena cava, blood cannot come into the heart because it's already overloaded. So what it does that it starts to accumulate fluid in these vena cavas. When superior vena cava becomes overloaded, you get raised JVP, which is one of the commonest feature of right heart failure. Due to inferior vena cava getting overloaded, we know that inferior vena cava takes blood from lower leg. Now, inferior vena cava is not able to do it because it's also overloaded. So then you get pedal edema. So you get swelling in the foot and ankle. In the same way, liver sends blood by portal vein. Now, portal vein is also congested. So because of portal vein becoming congested, the liver starts to become overloaded as well, causing hepatic congestion. And that gives tender hepatomegaly in a patient with right heart failure. Okay? So now you can understand. Now, this picture looks really horrible now, but I hope you guys actually understood. So this is how the system works. This is how you get all the symptoms of heart failure. So the commonest presentation of left heart failure is features of pulmonary edema. And pulmonary edema, patient will come to us with shortness of breath on exertion. They will have orthopnea, which means when they lie down, they will get more puffed out or more short of breath. And if you listen to their chest, you will get bibasilar crepitation because of all fluids, right? So this is the commonest presentation of left heart failure or pulmonary edema. What will be the feature of right heart failure? Right heart failure will have raised JVP, pedal edema, and tender hepatomegaly. Okay, so that's the main basic of heart failure and how all the symptoms in our body actually happens in heart failure patients. Does it make sense for everyone? Okay, let's move on to the main scenarios. So heart failure can be different types, and we divide heart failure in multiple different ways. So one, it could be systolic heart failure. Another could be diastolic heart failure. One, it could be that patient having right heart failure. Another can be left heart failure. So multiple ways we can differentiate the heart failure. Yes, that's right. So there will be ascites in right heart failure in the same way because of congestion. Now, for someone who needs to be a bit faster, Dr. Amira, I can become very, very fast, but most of you will not understand me. So if I'm a bit slow, it's for your understanding. I can become very, very fast. I can finish heart failure in 5 minutes, but that's not going to any any good impression, and also you will not understand a lot of important things. So I want to go slow today so that you understand, and then we can go faster. So we were talking about heart failure in summary. So heart failure presents with lot of symptoms, as we know. Their main presentation will be shortness of breath on exertion. They will have orthopnea, which means when they lie down, they will get more short of breath because of gravity. Because when they lie down, all the fluid starts to go into the lung. These patients can have weight gain because of fluid accumulation in the body. They have ankle edema. They have abdominal discomfort because of hepatic congestion. And they become very fatigued and lethargic. So left and right heart failure, we already talked about it, that what are the main symptoms that we can get in this patient. The main finding is bilateral basal crepitation in left heart failure, and you can get a S3 gallop rhythm in this patient as well. That's the most common physical examination finding in left heart failure. In right heart failure, we get raised JVP, peripheral edema, hepatomegaly. We know about this. And also sometimes we can get ascites. Now moving on to some of the different type of heart failure. Systolic and diastolic heart failure. So systolic heart failure is common. So if you remember, systole means that when heart contracts. If that contractility is failed, that means if heart cannot contract as it should be, it will not be able to pump blood into your body. That is systolic heart failure. So classic heart failure is systolic failure due to an inadequate pumping action of the heart. So how we can find out the pumping action? So sometimes we know that if the pumping action of the heart is working fine or not. So there is a way. Do you know how we measure that? So we measure the heart pumping action by doing this ejection fraction. So if you do an echocardiogram of the heart, echocardiogram will be able to say that how much is the pumping action or how much blood heart is able to pump out. And that ejection fraction gives us a very important clue that whether a patient is developing heart failure. So if a patient's contractility is low, then they can't pump enough blood to the heart, to the rest of the body. And that will show that ejection fraction is low because ejection fraction depends on cardiac output. And in patient who doesn't have good contraction, cardiac output will be low. So ejection fraction will be low as well. Now, what is the normal ejection fraction? Normal ejection fraction is above 50% according to therapeutic guideline. Okay? But most of the patient who has heart failure, they will start to get the symptoms when their ejection fraction becomes less than 40%. There is a name we use nowadays. We no longer use the term systolic heart failure. We use the term called heart failure with reduced ejection fraction. So HFrEF, that is the term that we use. So heart failure with reduced ejection fraction, that is nothing but systolic failure. And this one is only we can say when our ejection fraction shows less than 40%. What's in between? Between 40 to 50%, if a patient has symptoms of heart failure, there is a name nowadays we use. It's called heart failure with mildly reduced ejection fraction. So HFmREF, heart failure with mildly reduced ejection fraction. That is also a systolic failure, but this patient is in between 40 to 50%. They usually doesn't have a lot of symptoms, but these are the group of patients who can eventually become a full-blown systolic failure patient. Okay? Now, apart from systolic heart failure, the another type of heart failure is diastolic heart failure. Diastolic heart failure means, diastole means relaxation of the heart, which means heart is not able to relax to take the blood inside. Because for the heart to take all the blood from vena cava, it needs to be relaxed. It needs to be bigger so that it can take the blood in. Now, in diastolic heart failure, they lose that capacity. So it is the impairment of the left ventricular filling. So in diastolic heart failure, the heart is able to pump blood normally. So their pumping action is fine. The problem is that it's not taking enough blood in. It's not relaxing. So what will happen to the ejection fraction? Ejection fraction will be normal. Okay? So in this patient, you will not get any problem with the ejection fraction. And that is called heart failure with preserved ejection fraction. Okay? So if they use this kind of term, that heart failure with preserved ejection fraction, think that they're talking about diastolic heart failure. And a lot of times we get a patient who has all the symptoms of heart failure, but when we do their echocardiogram, the ejection fraction shows normal. That is the time you will think that possibly this patient has got a diastolic heart failure. So it should be suspected in the elderly patient with hypertension and a normal heart size on chest X-ray who comes to us with dyspnea. So if an elderly patient comes to us with shortness of breath and then they have a hypertension but normal heart size, because patient who has systolic heart failure, their heart size gets bigger because they starts to become hypertrophied to pump the blood, right? So if you do a chest X-ray in a systolic heart failure patient, you will get cardiomegaly. But in diastolic heart failure, the problem is that it does not relax, which means that the heart size will be normal in this patient. Okay? So you will not get any cardiomegaly in this patient as well. So this is what I have written in here. So you can give it a read, heart failure with preserved ejection fraction. What are the causes? It is possible, yes. Normal ejection fraction is possible because heart is taking blood in. So it's not like heart is not getting any blood. It's taking blood, and whatever it's getting, it is pushing it out. But sometimes what can happen that it's not enough. So causes of heart failure. So we know there is systolic heart failure. Problem is the pumping action. Diastolic heart failure. Problem is ventricular relaxation is the issue. Systolic heart failure, the commonest cause is ischemic heart disease. Approximately two-thirds of systolic heart failure patient has underlying ischemic heart disease or previous myocardial infarction. Hypertension can be a cause. Diastolic heart failure has a lot of causes. So hypertension can cause diastolic heart failure. Even ischemic heart disease can cause this. Aortic stenosis, which is a valvular heart disease, can cause this. So many of these can be a cause of diastolic heart failure. Now that we know the difference between systole and diastolic heart failure, our next step is that how to investigate this patient. So let's say you have got a patient, 50-year-old, coming to you with swelling in his ankle, shortness of breath on exertion. What will you do as your initial or next most appropriate investigation? What is your next appropriate investigation in a patient who is coming to you with a possible features of heart failure? Guys? ECG. This is why I asked this question, because many of you will say echo. Have you ever done echo in a patient without doing an ECG? Have you? I don't know if you have done it, that's wrong because you should not. So you need to make sure, because you have just learned that two-thirds of patient who comes to you with heart failure can have an underlying myocardial infarction or ischemic heart disease. So definitely you need to do a ECG first. ECG will be always your initial next most appropriate investigation. It might not be able to diagnose heart failure, but it can rule out a lot of underlying cause. If the question asks you that what is the most appropriate investigation or what is the definitive investigation, that will be echocardiogram. And echocardiogram is able to differentiate whether it is a systolic heart failure or diastolic heart failure. What else we can do? We can do a chest x-ray, because we know that in chest x-ray, if a patient has pulmonary edema, we can find it out. If there is a cardiomegaly, we can find it out. Let's say there is a rural hospital where echocardiogram is not available. Is there any alternative blood test we can do to sometimes? Now we do that test just to monitor the progression of the heart failure, but is there any test that we can do for that patient? Yes, BNP. So B-type natriureteric peptide, it is an indicator of severity of congestive cardiac failure. So it is a prognostic marker. Remember, BNP is not a diagnostic test, but sometimes in rural hospital or rural areas where echo might not be very much available, in that case, as an alternative, you can do BNP. Okay? But it is a test that we would do in a known heart failure patient to know their prognosis, to know how bad it is. So echocardiogram is the test of choice to confirm the diagnosis of heart failure and also to classify the type, as we know. So we have diagnosed a patient with heart failure. What next? Management. Management of heart failure comes a lot in different ways, in different versions. So you need to be very, very well known with this. So first of all, I'm going to discuss this heart failure management from therapeutic guideline, and then we will come to John Mortbeck. So this is from therapeutic guideline. All patient with a heart failure with reduced ejection fraction. That means we are talking about systolic heart failure. So every patient who has systolic heart failure this medication can be started all together. So this 4 medication, ACE inhibitor or ARB, heart failure specific beta blocker like atenolol, metoprolol, MRA, which is like a spironolactone or eplerenone, SGLT2 inhibitor like dapagliflozin or empagliflozin. These are the 4 medication that we need to start every patient. So this is quite different from what you will learn from John Mutter, but this is not what we practice in Australia. So as I always say that John Mutter, it is good. It is really good for preparation, but some of the management is not the best. So most of the time, management I will discuss from therapeutic guideline, RSCGP, those guidelines. If something is good in John Mutter, definitely we will do that as well. But it will always be a combination of where it is written best. So first of all, we have got a patient who has systolic heart failure. The next thing we notice is this patient congested or euvolemic? Very important. So congested patient means that they have got all the edema. They have got ascites, they have got pedal edema, they have got pulmonary edema. So in a patient who is congested, at diagnosis or within 2 to 4 weeks, we will start ACE inhibitor, MRA, which is your aldosterone, spironolactone, and SGLT2. So these are the 3 medications that we can start when a patient is congested. We can't start the beta blocker because if the patient is having congestion, beta blocker can make it worse. Okay. So according to the guideline, at diagnosis or within 2 to 4 weeks, we can start ACE inhibitor like ramipril, perindopril, those medications, MRA, which is the mineralocorticoid receptor antagonist, and that's your spironolactone, and SGLT2 inhibitor, which is your dapagliflozin or empagliflozin. Then once patients become euvolemic, which means there is no longer congestion, then you can start the patient with beta blocker. If patient is euvolemic, you start all the 4 together. Okay? Now start or continue. So what we do that we continue to monitor the dose, and every 2 to 4 weeks, we increase the dose of this medication to see how the patient is doing. And we aim to achieve the target or maximum tolerated dose of all these 4 drugs within 2 to 3 months. So what we do that we can't start all medication in the highest dose. We gradually increase the dose as the patient tolerates. And we achieve the maximum tolerated dose within 2 to 3 months. And then we do a repeat echocardiogram in 3 to 6 months to see how the ejection fraction doing at the moment. Now, after 3 to 6 months of maximum tolerated dose of this 4 medication, if a patient is still having ejection fraction less than 40%, then we are going to change the ACE inhibitor to ARNI, angiotensin receptor neprilysin inhibitor. ARNI is a combination of sacubitril plus valsartan. So valsartan is angiotensin receptor blocker, right? And sacubitril is a medication which inhibit neprilysin. Now, neprilysin is an enzyme. This enzyme breaks down our good peptides, which is ANP, BNP. BNP is important because it helps our heart muscle not to get too much strained. So it reduces the strain on the heart. It helps with salt and water excretion. So it's a good peptide. Naprolysin break down this BNP. So what we do that we give a medication which inhibit this naprolysin so that it cannot break down the BNP anymore. Okay? So sacubitril mainly helps in this way. So it reduces the heart strain, it increases the water and salt excretion. And we know the valsartan, like definitely it helps with angiotensin receptor inhibition, which also reduce the water accumulation in the body. Okay, so this is our step-by-step management. So it's very nice and easy according to therapeutic guideline. And this is the latest or the most updated version of heart failure treatment. Any other heart failure treatment you will come across that is not updated. And because I'm practicing in Australia, I know exactly what I would prescribe in a heart failure patient, and that's exactly what I would do, and any other doctor would do. Okay, so make sure to understand this. And if you have any questions, just ask me, please, now. So, did you guys understand the management of heart failure? There's like systolic heart failure. What will you do? So naprolysin is not needed. So we should not waste a lot of time on this. So just remember that sacubitril is a medication which inhibits naprolysin, and by inhibiting the naprolysin, it's helping our body to get rid of the excess salt and water. Yes, definitely. So that's a very good question, Laiba. That if you start RNA, because remember, if a patient still less than 40%, then we change the ACE inhibitor to RNA. So because it has the same ACE inhibitor and ARB is the same. So you have to stop the ACE inhibitor and then change it to RNA. Spironolactone is an aldosterone blocker, and aldosterone causes retention of water, if you know, right? So the function of aldosterone is retaining salt and water. So, and that is the problem in heart failure patient. And if you can block the aldosterone, these things can be easily reverted. That's why we use the aldosterone blocker as a diuretics. Okay. It's not like we don't use other diuretics. We do use diuretics like furosemide in heart failure patient, but that's for different reasons. We will come into that. Okay. I hope it's clear for everyone. Now, I no longer discuss the heart failure from John Mottag because John Mottag makes it a bit confusing. So I would say that please do not follow this anymore. Okay, follow what I have just shown you. That will be enough to pass your exam. Now, while we are at it, I would like to just show you a few things from therapeutic guidelines about the heart failure. So just give me a moment. So we discussed up to this that what we do and all. Monitoring drug therapy is not really important. Renin-angiotensin. So all of these, you don't need to know the dosing or any of this. So all you need to know is the name of the medication. That one by one what we do. Okay, so you really don't need to go through any of this. So you guys are asking that you might think that about the beta blocker. Always remember, do not start beta blocker during a period of acute decompensation. That means if a patient of heart failure suddenly gets deteriorated or has signs of congestion, do not start the beta blocker, because beta blocker can reduce the heart rate, and it can cause like more reduction of pumping of the blood, and that can be really troubling for congested patient. And the common beta blocker that we use in heart failure patient is bisoprolol, carvedilol, metoprolol, or nebivolol. Please remember these names because these are the heart failure beta blocker. These are the specific heart failure beta blocker or cardioprotective beta blocker. So bisoprolol, carvedilol, metoprolol, or nebivolol. Okay. We know about the MRA, which is the mineralocorticoid receptor antagonist, eplerenone and spironolactone. That's fine. What about these SGLT2 inhibitors? SGLT2 inhibitors, it reduces the cardiovascular mortality and hospitalization for heart failure patient. How it helps? It directly protects the kidney. So in a patient with heart failure, if we want to protect their kidney, because kidney is the first organ which is going to be affected when heart fails. So to protect the kidney, we give these SGLT2 inhibitors. Any of this is fine, but commonly we use dapagliflozin, known as 4-ziga in Australia. Okay. There are other drugs that sometimes we use in heart failure patients, like loop diuretics. So you guys were asking that why don't we use any other diuretics? We do use it, but we use loop diuretics only for patient who has like excessive congestion. So if a patient has signs and symptoms of congestion, like they are breathless because of pulmonary edema, or they have peripheral edema, for that congested patient, we can use the loop diuretics. Okay, and for them we can use furosemide or bumetanide. Any of this will be fine. There is another thing called ivabradine. So ivabradine is also used sometimes in heart failure patient. So it reduces cardiovascular death for heart failure in patients who are in sinus rhythm and have a heart rate of 70 beats per minute or more, despite taking maximum dose of beta blocker. So if you are giving beta blocker treatment to a patient and patient is still having heart failure symptoms and their heart rate is above 70, for that patient we use ivabradine. So ivabradine is only indicated if a patient is on an existing beta blocker treatment like bisoprolol or any of the other. Even with the maximum dose, still patient is in heart failure symptoms. And also we say that if ejection fraction goes below 35%, in that patient we can change that beta blocker to ivabradine. Nowadays, digoxin is no longer our priority for heart failure patient. Okay, so it's very rarely we would use. So that's mostly it that you need to know for heart failure medication. Okay. Now, two other things that we should know. So right now we have learned about heart failure with reduced ejection fraction. What about this heart failure with mildly reduced ejection fraction? So remember I was saying that there is a group of patients whose ejection fraction can be between 41 to 49%. For this group of patients, we will use the same medication that we used for the systolic heart failure patient, only if they have features of heart failure. So even if a patient has ejection fraction between 41 to 49, but they have sign and symptoms of heart failure, then we'll be using all this medication, which means SGLT2. We can use all the others like ACE inhibitors, beta blocker, MRA, all of this can be used if a patient has sign and symptoms. Okay? So basically, it depends on the sign and symptom that whether in a mildly reduced ejection fraction patient, we are going to start the medication or not. If they have symptoms, we will start it. If they don't have symptoms, we just monitor it. Now, how about this diastolic heart failure patient? Remember, diastolic heart failure patient, the problem is they don't relax their heart. So for them, ejection fraction will be normal. Their ejection fraction will be more than 50%. So the most important thing is to find out the cause. If they have hypertension, you treat the hypertension and their heart failure will get better. So find out the cause and treat it. That's the main thing. What else we can use? So SGLT2 inhibitors has shown that it can reduce the risk of cardiovascular death in a patient even with preserved ejection fraction. That means even in diastolic failure patient, this medication can reduce the risk of cardiovascular death. So very important medication. Sometimes if we need to treat their high blood pressure, we can use ACE inhibitor or ARB. We can even use spironolactone in this patient. So all other medication can be used in preserved heart failure patient as well. Okay. Now, if we go back to our note, in diastolic heart failure, management based on treating the cause, such as hypertension, ischemia, diabetes, the basic treatment is with ionotropic agent, such as calcium channel blocker or beta blocker. So if the question asks what is the main treatment for diastolic heart failure, the main treatment is beta blocker or calcium channel blocker, because these blockers can reduce the heart rate. And if it can reduce the heart rate, heart will get enough time to relax. So this is the basic or the most appropriate medication. So beta blocker or rate limiting calcium channel blocker. Apart from that, we can use others like ACE inhibitors. We can use spironolactone if needed. So those can be used, and also dapagliflozin, but this will be the first line. Okay. So that's mostly all about the heart failure difference and management. Quickly, I will go to congestive cardiac, uh, acute pulmonary edema, and also some of the common drugs that we use in heart failure and what are their side effects. So pharmacology is really important. So you need to know some of the common drugs side effect. So these commonly used diuretics in heart failure, like thiazide diuretics, loop diuretics, and potassium sparing diuretics, you need to know what are their possible side effects. Like thiazides can cause hyponatremia, it can reduce potassium, it can increase calcium, it can increase uric acid, so we don't give this to patient who has gout. It can also cause impaired glucose tolerance. So someone who has got a very high uncontrolled diabetes, thiazide diuretics is not the best option for them. So among thiazide, hydrochlorothiazide is most commonly used, and sometimes we can use indapamide as well. These are the same thing. Loop diuretics has furosemide, which is commonly the one that we use. And then there is bumetanide. If we can't give furosemide, we go for bumetanide. This causes all the electrolyte will become hypo here. Hyponatremia, hypokalemia, hypocalcemia. Okay. It can also cause ototoxicity. It can cause nephritis or interstitial nephritis. So these are the common side effects we should know of. And as part of potassium sparing diuretics, as it says potassium sparing, it means it causes hyperkalemia. Okay. And it is one of the commonest cause of gynecomastia as well. Along with spironolactone, another common cause of gynecomastia is digoxin. So these are the two commonest ones. Okay. Clear everyone so far? Now, the one other thing that someone who you have tried everything, every possible management for heart failure, but they are not getting better. Heart failure patient has an increased risk of dying from cardiac arrest. So the last option is to put them on a automatic implantable cardioverter defibrillator. So in a patient who has dilated cardiomyopathy and their ejection fraction is persistently less than 35 despite trying all possible medication, that is one of the patient who can go for this implantable defibrillator. What it does that if patient goes into cardiac arrest, it will just like shock the patient by itself. Okay, so that is the last option for heart failure patient, especially if it is related to cardiomyopathy. Now, let's finish heart failure with pulmonary edema. Pulmonary edema, as you know, that when the lungs start to get fluid overloaded, and it is a medical emergency, it requires hospitalization, right? So if you do an X-ray on a pulmonary edema patient, you will see that there will be this kind of like whitening of the lung shadows. Most importantly, you get this batwing appearance. See this batwing appearance? This, this opacity bilaterally, like a bat wing, is a classic picture of pulmonary edema in a chest X-ray. So how the patients with pulmonary edema will present to us? So because their lungs are full of fluid, they will come to you with severe shortness of breath. That is the first presentation. You'll see that they are puffing out. So severe shortness of breath, their respiratory rate, heart rate will be elevated. And you might also see that they will complain orthopnea. They will also, if you examine their lungs, you will get bibasilar crepitation. So that is usually the main presentation. So increasing shortness of breath, orthopnea, they can also have paroxysmal nocturnal dyspnea, which is a condition, which is a symptoms that patient in the middle of the night sit up gasping for air. And this happens multiple times overnight. So these are all the possible features of pulmonary edema. And when you examine the lung, if you hear bibasilar crepitation, that's it. That is the pulmonary edema. What do you do next? So pulmonary edema patient, your initial test should be a chest X-ray, which will give you the proper diagnosis. And you should also do a ECG as well. What will you do as part of treating a pulmonary edema patient? What is the first thing that we do, guys, in a pulmonary edema patient? Tell me. The first thing is propped up position. You keep the patient sit up, yes, because that's the first thing that you can do without doing anything. And yes, we need to make sure, we need to measure their oxygen as well. That's right. So propped up position should be the first thing we would do. And then check the oxygen. If patient needs oxygen, start the oxygen. So acute cardiogenic pulmonary edema presents as rapid onset severe dyspnea as well as tachypnea, tachycardia. They can also get like sweaty, cold peripheries. They can become agitated, restless, and widespread lung crepitation can be there. So what is the initial treatment of this kind of patient? So definitely this patient needs urgent hospitalization. Even in the ambulance or while waiting for the ambulance, start furosemide for this group of patient. So many times this patient will need IV furosemide or IM furosemide. So furosemide plus, if oxygen saturation is less than 92, you start the patient with a high flow oxygen with a mask. Okay? Let's say if clinical response to oxygen and furosemide is inadequate, what will be the next? So you started furosemide, you started oxygen when the saturation went down to 92 and less. Still, patient is not showing features of improvement. That means they are still looking very short of breath. Then you add glyceryl trinitrate. Okay, so glyceryl trinitrate can be used sublingually, or you can use it you can use it as a spray. You can use it like a sublingual tablet as well. Okay, so this is actually the treatment of pulmonary edema. So you would give furosemide, oxygen, glyceryl trinitrate, and even after that, let's say you have given high flow oxygen, you have given furosemide, you have given glyceryl trinitrate, it's not getting better. In that case, you do a arterial blood gas analysis, ABG. If the ABG shows that patient has features of respiratory acidosis, that patient will go for non-invasive ventilation, which is the CPAP. Okay, now there is a lot to learn about these kind of things. I'm not going into that deep. You will learn about this ABG thing later on in the course, but just remember that this is the step-by-step management. Because this kind of patient becomes very restless, agitated, anxiety and distress can make the heart much worse. For that patient, for this group of patient who looks very agitated, restless, we give morphine because morphine can reduce their agitation. It can make them calm. Okay, so that's mostly all you need to know from cardiogenic pulmonary edema management. Okay, so to recapitulate, we need to prop up the patient, like sit up the patient upright, and furosemide, oxygen, morphine, nitroglycerin, and then if needed, CPAP. Okay? Everyone all good? Clear? All right, I think we should definitely take a 5-minute break to give you a little bit of brain clarity. There's a lot that you have learned. I'm sure many of these you have never seen or learned, right? So let's take a 5-minute break and then we will come back and we'll start with the Thanks everyone. 5-minute break, please. All right, everyone, let's continue then. So we finished heart failure. Now we're moving on to valvular heart disease. So valvular heart disease, the common thing that comes in exam is mainly the types of murmur. That's mostly it. So you need to know how to detect like what are the common murmurs in various valvular heart disease. Okay, so let me discuss this in a way that I usually remember. There is no easiest way to remember murmur. It is difficult, I know, and there is no mnemonic that can help you to remember it. So you need to be smart to know the commonest ones. So if you know that, so if this is the sternum, and then we have got, these are our intercostal space, let's say. So let's say this is our second intercostal space. That's the third, this is fourth, and that's fifth. This is the right side, this is the left side. And if we see that heart is staying like this, okay? So over here, that's the apex, which is commonly on the, like mostly on the left fifth intercostal space, right? So apex is on the left fifth intercostal space. And that's where we normally get mitral valve murmur. Now, there are four valves that is important to know if you remember when we were talking about this. So two valves on the right side. So this is the tricuspid valve, and the one that goes for pulmonary artery, that's our pulmonary valve. These two valves, usually this is not important for exam. The murmurs associated with them doesn't come in exam. But the murmur related to mitral valve and the aortic valve is important. Okay. Now, tricuspid valve is commonly the murmur of tricuspid valve. You will find it in the left fourth intercostal space along the sternal edge, just around here. So this is the left fourth intercostal space. So we know mitral valve murmur, best is around the apex. Then tricuspid valve, the murmur is commonly heard on the left fourth intercostal space, but it is along the sternal edge. Then we have got aortic valve and pulmonary valve. As you see, the pulmonary valve goes from the right towards the left side, right? Like this. That's why, excuse me, that's why you'll see that the murmur of pulmonary valve usually best heard on the second left intercostal space, just over there, because it goes like this. So pulmonary valve murmur best heard on the left second intercostal space. And in the same way, aortic murmur, it goes like this. So that's why it's best heard on the right second intercostal space. Now that is the aortic stenosis murmur. This is commonly heard on the right second intercostal space. The only anomaly is aortic regurgitation murmur, which is best heard on the around the same area where tricuspid murmur is heard, which is left fourth intercostal space along the sternal edge. Okay, so this is the common site of murmur, and it will help you in the exam to rule out some of the common options. Now that you know the different site of the murmur, the next step is to know different, like what are the murmur sounds. So the first of all, I remember only one murmur, which is the mitral stenosis murmur. Mitral stenosis murmur is a mid-diastolic murmur, and all mitral murmurs best heard in the left fifth intercostal space. So it's a mid-diastolic murmur. Okay? Now, for this smart way, we will be able to find out all the mitral and aortic murmur by this method. So just for the sake of understanding, remember that opposite of mitral, we will think that it is aortic, and opposite of stenosis is regurgitation. So just for remembering, it's not actually opposite. So we just remember mitral opposite is aortic, and stenosis opposite is regurgitation. So mitral stenosis and aortic regurgitation, the murmurs are diastolic murmur. But aortic regurgitation, the murmur is called early diastolic murmur. Okay? Now, what is left? We have done mitral stenosis, so mitral regurgitation is left, and aortic regurgitation is done, aortic stenosis is left. These two are systolic murmur. Now, mitral regurgitation murmur is a pansystolic murmur, and aortic stenosis murmur is an ejection systolic murmur. Okay, so just by remembering this, you can easily remember all these three. And that is the only way for me to give you the way to remember them. If you forget in the exam, this is how you can easily remember. Did it make sense for everyone? So mitral stenosis is a mid-diastolic murmur. What is the opposite? Opposite of mitral is aortic. Opposite of stenosis is regurgitation. So aortic regurgitation is also diastolic murmur, but it is early diastolic murmur. Whatever left is a systolic murmur. You just need to remember aortic stenosis murmur is an ejection systolic murmur, and mitral regurgitation is a pansystolic murmur. Now, these two murmur also radiates. Mitral regurgitation murmur radiates to axilla, whereas aortic stenosis murmur, it radiates to carotid or to the neck. Okay? Make sense? Everyone? Clear? So if you can remember in this way, it becomes very easy. So I have given some of the common murmur. So you can see aortic regurgitation murmur. So these are the common one. You need to remember these aortic and mitral murmurs. These are the common one that will come. Others are not that important. If you want to memorize all murmurs, then you can go to these med bullets, and in the med bullet, you will be able to see all the murmurs. So if you want to do that, it's fine, but the commonest one is aortic and mitral murmur. If you can remember them, you'll be fine for exam. Now, most of the murmur or most of the valvular heart disease, the treatment is usually just wait and watch and see how the patient goes, except aortic stenosis murmur. So I will just give you a slightly good idea about aortic stenosis because this is the commonest valvular heart disease in elderly population. Aortic stenosis, patient will come to you with a triad of chest pain or chest tightness on exertion. They will come to you with dyspnea on exertion, and they will also come to you with sudden syncope or dizziness or blackouts. This is the triad of symptoms of aortic stenosis, and these are usually elderly patients. And when you examine this patient, you get this ejection systolic murmur, which radiates to axilla. When you get these symptoms, how you are going to confirm the diagnosis? To confirm the diagnosis, you need to do an echocardiogram. Echo will be able to say, yes, there is aortic stenosis, and it also says how bad it is. The guideline is there is no medical treatment that can cure aortic stenosis. The only treatment for severe aortic stenosis is surgical correction. So severe aortic stenosis means that when echo will say that the stenosis of the aortic valve is now less than 1 centimeter. That means the area of the aortic valve, because of the stenosis, is now less than 1 centimeter. That means there is a very small area left for the heart to pump blood to the aorta. So if that is echo, if echo mentioned that, it becomes severe aortic stenosis. For a severe aortic stenosis, the treatment is valvular replacement. So nowadays, so you can do, so previously people used to do pig valve or cow valve. So that they can replace the valve with the pig valve. So pig or cows. So that's a biological one. And then also there are like mechanical prosthetic heart valve, which is made of titanium. So that's what is the indication to go for this kind of like this kind of heart valvular replacement in aortic stenosis. Okay, clear everyone? And nowadays there is a new version of this heart valve replacement. It's called TAVI. TAVI uses a catheter to implant the aortic valve. So the TAVI means transcatheter aortic valve implantation. So TAVI is the commonest procedure for aortic valve replacement nowadays. Okay, where they can use a catheter which goes into the heart, goes into the exact aortic valve area, and then they put this new valve. Okay, so just this one is the one that's important to know. So please remember them. Otherwise, you should be fine. Moving on to cardiomyopathies. So cardiomyopathy, there are three types of cardiomyopathy. One is dilated cardiomyopathy. Then we have HOCM, hypertrophic obstructive cardiomyopathy, and then restrictive cardiomyopathy. Dilated cardiomyopathy means that patients has diminished myocardial contractility. So in dilated cardiomyopathy, the heart becomes dilated. So if we see here, this is the normal heart. And patient who has dilated cardiomyopathy, the heart became very much like enlarged. So when it becomes enlarged like this, it loses the contractility. It can't contract as it should be. So if it can't contract, what kind of heart failure we will get in this patient? Yes, if heart cannot contract, we are going to get a systolic heart failure, right? Because that means contractility is the problem. So in these patients, the main presentation will be that they will come to you with a systolic heart failure symptoms. The commonest cause of dilated cardiomyopathy is idiopathic. We don't know. Other than that, alcohol is another common cause, and lots of other causes can be there. So as I said, this patient will come to us with systolic heart failure complaint. The treatment is as if the same treatment that we would give for systolic heart failure. Okay. Now, the next one is very, very important for exam, HOOCM or HOCM. Now, HOCM In 60% cases, it can be hereditary, which is autosomal dominant. So the hallmark of this disease is that it causes thickening or hypertrophy of the interventricular septum. Have a look. This is the interventricular septum, which separates these two ventricles, right? And have a look to the hypertrophied left ventricular cardiomyopathy. So if you see this one, see that how much it is thickened. So especially all the muscle in the left ventricle, including the septum, will become hypertrophied. The problem is that when it becomes hypertrophied, it is too much strong, right? So it can contract so fast that sometimes the ejection fraction can become 80 to 90% because the muscle is very strong, right? The problem is that this patient who has this much strong muscle like that, their problem will be that they can't relax. Their contraction is good, but it can't relax. So as a result of the hypertrophy, left ventricular compliance is reduced. So compliance means that even if the heart is taking blood, there is no space in the left ventricle to bring the blood because there is not much of a space there. Okay? And that is what happens in HOCM where left ventricle doesn't have enough space, but because the small amount of blood that can come here, it can contract super fast. So diastolic dysfunction is characteristic in this patient. Okay? So the heart is hypercontractile, ejection fraction often 80 to 90%, but there will be diastolic failure in this patient. Okay, so presentation will be like same shortness of breath. They can have syncope, palpitation. You can get a bifid or bifid carotid pulse, S4 gallop rhythm. So this can be found in this patient. Okay, so same way you do ECG first. In the ECG, you can get left ventricular hypertrophy because you can see it is already hypertrophied. So that is the first finding you can get in the ECG. The only way to confirm is echocardiogram. Now, sometimes if it is not that bad, like early stage, if you do a resting echocardiogram, the resting echo might be normal. So if you have a strong suspicion means that HOCM patients are quite young. And young patient, while let's say while playing or doing some sports, suddenly lost consciousness, and then they regained consciousness very suddenly, and there was no prenormal symptom there. And so basically, it is a cardiac syncope where patient lose consciousness suddenly and regain consciousness suddenly. But there are lots of other syncope, like if a patient gets vasovagal syncope, they will get dizzy, lightheaded before they fall. But this patient who has cardiac syncope, they fall suddenly and then they lose consciousness and then they get up as if nothing has happened. So they will present to you with this kind of sudden syncopal attack, young patient, and there will be a family history of sudden cardiac death in earlier stage. That is the time you should think that, well, this patient might have HOCM. If there is a strong suspicion that, well, this could be HOCM, then even if the resting echo is normal, you get to do a stress echocardiogram. And that is what comes in exam sometimes. Okay? Now, once a stress echo usually will be able to confirm the diagnosis. Once it is diagnosed, the treatment is same as if you are treating a diastolic heart failure, which will be beta blocker, calcium channel blocker. Okay? Make sense, everyone? All right, so why we avoid diuretics? Good question. So because diuretics will get rid of the fluid volume. Now these patients already, their heart is not getting enough blood. And if they lose more fluid, it will become more harder for the heart. Okay, that's why diuretics are not needed for diastolic heart failure. Why there will be systolic dysfunction? Systolic dysfunction means that the heart is not able to contract. But see, these muscles are quite strong. So these can contract quite fast and quite easily. So there is no way that there will be any systolic problem in this patient. And diastolic dysfunction because there is not much of a space in here for the blood to come in. Okay. There is another cardiomyopathy, which is called restrictive cardiomyopathy, not very important for exam. Restrictive cardiomyopathy is a condition where the heart, the wall of the ventricle becomes stiff and it becomes restrictive. Like patient who gets infiltrative cardiomyopathy, amyloidosis, sarcoidosis, those things. It's very uncommon. It doesn't come in exam. Just remember, in restrictive cardiomyopathy, the heart becomes rigid, and because it becomes rigid, it can't pump the blood, nor it can relax. So this patient gets both systolic and diastolic dysfunction. That's why there is no good treatment for it. And ultimately, the only way to cure this is heart transplantation. Okay? So moving on, we discussed about acute pericarditis in our last session, so we don't need to discuss that anymore. Pericardial effusion. So sometimes patient who has some pericardial disease, they can have fluid accumulation around the heart. So we know that heart has the outer covering, which is the pericardium. Now, even sometimes due to pericarditis, there might be fluid accumulation. And if there is a fluid accumulation, that is what we call as pericardial effusion. How to diagnose this? So the only way you can diagnose pericardial effusion is echocardiogram. And sometimes if you do a chest X-ray, pericardial effusion gives this water bottle appearance. So basically the treatment is finding out the cause. And if it is becoming too much, then we aspirate the fluid. The problem that's more important is cardiac tamponade. So sometimes the pericardial effusion can become so bad or it can develop so rapidly that it can start compressing the heart itself, which is what we call cardiac tamponade. So sometimes what will happen that fluid will be too much. If it is too much fluid, it can start compressing the heart. So how they will present in that case? So patient with cardiac tamponade, definitely they will have shortness of breath, fatigue, they will have orthopnea. Now, they also get very common triad. The triad is called Beck's triad. Beck's triad has low blood pressure, so they get hypotension. They get distended neck veins, so raised JVP, and they get muffled heart sound. So if you have got a patient who's coming to you with acute shortness of breath, and then you see that they have low blood pressure and raised JVP, but when you try to listen to the heart sound, it's very muffled. You can't even hear it properly. That is one of the time you should think that, well, this patient might have a cardiac tamponade. Many times cardiac tamponade can be related to trauma. So like patient had a motor vehicle accident, that's very common presentation. In other ways, even sometimes heart failure patient, those patients can also have it, but most important is a trauma. So the clue to think of cardiac tamponade in the exam is if you get this triad, hypotension, raised JVP with muffled heart sound. What will you do? You will do an echocardiogram, and echo will say, yes, this patient has got a massive pericardial effusion. Then you need to do an urgent pericardiocentesis, which means you insert a large bore needle into the pericardial space and you take all the fluid out. Okay? Because ECG will not be able to diagnose this. This is a life and death situation, pericardial effusion. Life and death, these things you need to do a bedside ultrasound and like bedside echo. Bedside echo will be able to diagnose this. Depends on the presentation, Homer, that the pericardial effusion might not even have any symptoms. In those patients, yes, we will do ECG. But the question will ask you what is the diagnostic test or what is the most appropriate test. For them, yes, echo is the main investigation. But we can't always say that no, you will always need to do echo first, you'll always need to do ECG. Patient's presentation will dictate a lot of things. Okay, like a patient who has a motor vehicle accident and patient is short of breath, you can see that there is hypotension, muffled heart sound. In a real life scenario, we will be doing everything. Patient will be on a cardiac monitor. You can see the ECG. You do a bedside echocardiogram. So everything happens, right? So think, think in that way. In a real life situation, it depends on the patient's presentation, what we will do next. Okay? All right. So these topics are not super important, like this pericardial effusion, cardiac tamponade. You need to know them, but not super important. Same cardiomyopathy, not super important. HOCM is really important, but dilated cardiomyopathy, restrictive, those are not that important. Now, what is important is hypertension. Very important. Although it looks very easy, it can be really, really difficult if you don't know. If you think that every hypertensive patient needs to be on a medication, you will fail this. You will fail this chapter. So there is a lot to know about hypertension. John Muttag has a chapter which is chapter 77 in 8th edition. So that's one of the things that you should go through. And we will go through a little bit from therapeutic guideline as well. So first of all, learn about what is normal blood pressure. So optimal blood pressure is less than 120/80. Now, high normal, up to which we can tolerate that, yes, it is normal. So less than 140/90. That is the high normal. Up to this, we can still consider it normal. If it is more than 140/90, that becomes hypertensive. Hypertension is divided into mild, moderate, and severe based on this value. So you can remember them, you can read them and memorize them. So for adults aged 18 and above, hypertension is if you get repeated measurements of diastolic more than 90 and or systolic more than 140. Okay. Now, causes of hypertension, why hypertension happens. A lot of time patient ask me this. And the problem is that we have to always say that 95% cases there is no cause. And that is called essential hypertension. Only 5 to 10% cases there might be cause, but there is an extensive list. So out of 5 to 10%, kidney-related causes are the most common. So glomerulonephritis, renal artery stenosis, if a patient has got polycystic kidney disease, endocrine causes like aldosteronism, which is Conn's syndrome, Cushing's syndrome, pheochromocytoma. If a patient is on oral contraceptive, especially COCP, combined oral contraceptive pill, coarctation of aorta, some of the medication like steroid, NSAID, even pregnancy. So this can be the secondary cause of hypertension. So many times we would look for these secondary causes, but because 95% cases it is essential, that means we don't know, it's not must to send every hypertensive patient to a lot of tests to rule out this secondary hypertension. So there is a rule when we would do investigations to find out whether they have got any secondary hypertension. So what suggests that patient might have secondary hypertension? So some of these important clues will be there in exam, like if there is a renal bruit or abdominal systolic bruit, then we think of renal artery stenosis. If there is proteinuria, hematuria, or RBC cast, think of glomerulonephritis. If we can feel bilateral kidney mass, then polycystic kidney disease. Radiofemoral delay, we can think of coarctation of aorta. So these are important causes which might help us to think that, well, this patient might have something underlying causing the high blood pressure. Okay. Now, two other names you should remember: malignant hypertension and refractory hypertension. Although we don't use this malignant hypertension term in Australia a lot, but John Murtagh has given this term, so you should know. Malignant hypertension is when diastolic blood pressure is above 120. Along with that, they have retinopathy or nephropathy. Okay, so if the kidney or retina is involved and the diastolic is more than 120, we can say it is malignant hypertension. More important to know is refractory hypertension. So despite taking maximum dose of 2 drugs for 3 to 4 months, if a patient's blood pressure remain elevated, that is called refractory hypertension. Now, this is the group of patient where you should check for secondary hypertension, especially if it is a young patient. Elderly patient, not needed. But young patient, you needed to use 2 antihypertensive to reduce their blood pressure. Still, it is not working. You would definitely rule out secondary causes. Now, renal artery stenosis is one of the common cause of secondary hypertension. The most common cause is atherosclerosis. So if you know, so this is the abdominal aorta, and let's say this is the renal artery, and that's where you have got the kidney. Some patients who has a lot of atherosclerosis problem, they will start to have buildup of fatty plaques, and eventually it can get blocked, right? So renal artery stenosis, most of the time, it is caused by atherosclerosis. And then there is another cause called fibromuscular dysplasia. It is common in young female. If we suspect or if we want to rule out renal artery stenosis, specifically, there will be a renal bruit that you can feel, that you can listen by a stethoscope. If renal bruit or abdominal systolic bruit is positive, then definitely we need to send the patient for a Doppler ultrasound of the renal artery, and that can confirm the diagnosis. Now, coming back to the basic again, how we can detect hypertension. Is a single high blood pressure enough to diagnose a patient? No. Always remember that diagnosis should never be made on the basis of a single visit. If you have got a patient who has high blood pressure, this initial raised blood pressure should be confirmed on at least 2 other visits within a space of 3 months. So you need to do, your patient initial blood pressure was high, and you need to do another 2. And if the average of these 3, if the average level of 90 diastolic or 140 systolic, then you can say that yes, this is most likely patient who has hypertension. And this is another important thing. Every patient who is more than 18 should have a blood pressure check every 2 years at least. Now, coming to more important things. So you know that how we can confirm hypertension. To confirm hypertension, you need at least multiple high blood pressure reading. At least initial high blood pressure needs to be checked another 2 times. And then if you see, yes, still the patient is hypertensive, you can confirm that, yes, you have hypertension. Then what else? Once we diagnose someone, so let's say the follow-up is important. So this group, they're all right, right? So they're high normal group. For high normal group, we just repeat their blood pressure in a year and we advise them to continue lifestyle modification. This is mild hypertension. For mild hypertension, you have to confirm whether they have hypertension within 2 months and advise them to start lifestyle modification. If it is grade 2, you need to evaluate the patient at least within a month. And if it is really high, then within a week or sometimes even, we might need to even start the medication straight away. Depends on a lot of other factors. We will come into that. So remember this follow-up because sometimes they give you this. So you just need to know that for mild hypertension, we need to confirm within 2 months. For moderate, we need to evaluate within a month. And for severe, within a week at least. If mild hypertension is found, observation with repeated measurement over 3 to 6 months should be followed before beginning treatment. Remember that because mild hypertension does not require antihypertensive most of the time. You can ask the patient to do lifestyle modification before starting any treatment. Now, there is a thing called white coat hypertension, right? So when patient comes to visit you in your clinic, patient's blood pressure goes super high. But when you ask them that how is your blood pressure at home, they said it's completely fine. That is white coat hypertension. When there is a significant discrepancy between multiple blood pressure readings, then you can do a ambulatory blood pressure monitor. In ambulatory blood pressure monitor, you put a device, which is a blood pressure cuff, on their arm, and that cuff records the blood pressure for 24 hours, and then it gives an average. If the average is high, then you can say, yes, you don't have white coat, you actually have hypertension. So the main indication to do the ambulatory blood pressure monitor is when there is a marked discrepancy between multiple blood pressure reading. Treatment. Treatment is the most important thing. So the main treatment as a background, always lifestyle modification. So lifestyle modification, the main one is weight reduction. If a patient can lose 1 kilo weight, their blood pressure will drop by 2.5 systolic and 1.5 diastolic. So sometimes they will give you this kind of question. What has the best non-pharmacological way to reduce the blood pressure? That is the weight reduction. Then also ask the patient to reduce excess alcohol, reduction of salt intake to less than 4 grams a day, exercise, physical activity, reduce stress, stop smoking. So those are all important, but weight reduction is the most important. Now, when we start medication and what are the medication we have got? Let's go to therapeutic guideline for that. So before we think of starting a patient with antihypertensive medication, the first thing we do is we do a risk calculation. The risk calculation is what we call atherosclerotic cardiovascular disease risk estimation, ASCVD. In a simple way, we use a cardiovascular risk calculator to find out. We put every parameter on a chart, and then we find out what is the risk of a heart attack in this patient. Is it mild risk? Is it moderate risk? Is it a high risk patient? Based on that, we decide if we are going to start treatment or not. Okay? You can also see that for patient with consistently significantly elevated BP, which means consistently their blood pressure is above 160 or above 100, start drug treatment irrespective of the patient's risk estimation. So they say that definitely lifestyle modification will come into place, but this becomes a moderate hypertension. If they are persistent, means that they have tried lifestyle modification, did not work, and that means it is persistent or consistently elevated BP. For them, we will start treatment. Now coming to the risk assessment. So for patient who has high cardiovascular risk, nowadays the risk calculator has been changed. Previously, there was a different risk calculator. I want you to remember this risk calculation. So 0 to 5% means they are low risk. 5 to 10% is intermediate risk. And above 10% is high risk. So this is the new guideline, the Australian Heart Foundation guideline. So guideline says that if a patient's cardiovascular risk, so the calculator is, you will use the calculator to find that out, but in your exam, you don't need to do it. They will give you that. So if it is a 0 to 5% cardiovascular, that's a low risk. For patients who are low risk, blood pressure treatment is not routinely required. So this is the group of patients where you can even do 6 months of lifestyle modification and see how they go. And even if you don't start medication for them, it's not going to harm. For intermediate risk, consider starting blood pressure lowering treatment in addition to lifestyle modification, unless contraindicated or clinically inappropriate. Excuse me. So for intermediate cardiovascular risk patient, ideally we will start the patient with blood pressure lowering treatment. And if it is a high-risk patient, then definitely they need to be on blood pressure medication along with the lifestyle modification. So if you ask me that which group doesn't need antihypertensive, this low-risk group. But this moderate and high-risk group, they are the group who will need antihypertensive if they come to us with a confirmed high blood pressure. Okay? So in here, they have discussed about all of these different antihypertensive, which is not necessary for you to know. So let's go back to our notes. Now, let's say we want to start medication for a patient. What we can. Now, see that's why I'm saying that this was the previous risk calculation. John Murtagh still hasn't changed this because this has been changed all over Heart Foundation. But John Murtagh, because I think they have done the edition a bit earlier. So this is no longer the case. So if you follow this, you will be in a trouble. So low risk now is up to 5%, and up to 10% is moderate, and high risk is more than 10%. Okay? So this is the same thing. So maintain lifestyle for this low risk group for even 6 to 12 months. And let's say after 6 to 12 months, is still their blood pressure consistently high, you can consider blood pressure treatment. For moderate risk, lifestyle, you can go for 3 to 6 months. And if it is still high, then you can start treatment. For high-risk group, along with the lifestyle changes, you start treatment immediately for this group. So for high risk, we will always start treatment immediately along with lifestyle. For moderate risk, we can wait for 3 to 6 months for lifestyle modification. And then it's still high, then we can start treatment. Does it make sense, guys? Because this is really difficult. If you don't know this, it can become really complicated for exam. Okay, so these are our treatment options. So we have the most commonly we use ACE inhibitor or ARB. Then we have calcium channel blocker, or we have thiazide diuretics, which are commonly used after the age of 65. So you start any of this medication first as a monotherapy. So either you can start ACE inhibitor or ARB, CCB, or thiazide. If target not reached after 3 months, then you can combine them. Now, nowadays, although John Murtagh says that this is how you have to do it, but it is a bit different what therapeutic guidelines says. So I want you to know this because it's important. So you started a patient with monotherapy. If the blood pressure target has not been reached after 4 to 6 weeks, do not stop or change the initial drug, but add a low dose second drug from different class. Now, this is super important. Let's say you started a patient with ACE inhibitor. And it tried for 6 weeks. Blood pressure is still not coming down. Rather than increasing the dose of ACE inhibitor, add a combination. The combination can be ACE inhibitor with a diuretics or ACE inhibitor with a calcium channel blocker. Okay, so patients commonly require 2 or more drugs to reach the blood pressure target. So the best idea that you started a monotherapy, wait for 4 to 6 weeks, still not doing much, then you add a second medication in a low dose. Then what you will do? Let's say for patient who is taking the 2 drugs now, then you can adjust the medication dose one by one. So you can increase the dose of one medication, wait for 4 to 6 weeks, see how you go. And then you go to the maximum of that drug. Still not working, then gradually go to the maximum of the second drug. Okay? And it's still not doing anything, that becomes a refractory hypertension. Then you look for secondary hypertension causes. And then, yes, you can add 3 medication together. Like you can combine ACE inhibitor, CCB, and diuretics as well. Let's say, so if you are understanding me, let me go back. So let's say you have started a patient with ACE inhibitor or ARB in a low dose. And you waited for 4 to 6 weeks, nothing much. So you add ACE inhibitor or ARB plus a CCB or diuretics. And both of them are in the low dose now. After 4 to 6 weeks, nothing much happening, still blood pressure is high. Then you gradually increase the ACE inhibitor every 4 to 6 weeks to the maximum dose. It's still not getting down, then you increase the CCB or diuretics. Then let's say you come into the maximum dose of this medication. Then the option is combining all the 3, ACE inhibitor plus CCB plus diuretics. Still not working. you can add spironolactone. That's a good medication for refractory hypertension. Then we have lots of other options as well. Like we can use clonidine, we can use alpha blocker like prazosin, we can use minoxidil, okay? So lots of options are there, but those are a specialist level. You don't need to know them. Just know up to spironolactone or prazosin. That will do. Clear so far, the management, guys? Now, few things are important that you can't use antihypertensive, like there are different comorbidities which will detect what kind of antihypertensive we will start a patient with. So when you start a patient with an antihypertensive, look at their other comorbidities. Like for asthma COPD patient, beta blocker is not good because it can cause bronchospasm. For patient who has heart block or bradycardia, for them using beta blocker, calcium channel blocker is not good. For cardiac failure patient, especially if it is a systolic heart failure, we would be very careful with beta blocker and calcium channel blocker, especially if they are congested. For cardiac failure, ACE inhibitor, diuretics, these are okay. For diabetes patient, the best antihypertensive is ACE inhibitor because ACE inhibitor can also protect the kidney. For hyperuricemia or gout, we can't use the thiazide diuretics because it can increase the uric acid and cause gout. For peripheral vascular disease, the best will be calcium channel blocker because it can open up the narrow artery, right? So for peripheral vascular disease, if we need to give a blood pressure medication, calcium channel blocker should be our choice. Same with patient with Raynaud phenomenon, calcium channel blocker is better. For renal artery stenosis, remember that if it is unilateral renal artery stenosis, best antihypertensive will be ACE inhibitor or ARB. If it is bilateral renal artery stenosis, then we don't use ACE inhibitor anymore, we use calcium channel blocker. Okay, so these are the common things that we remember. Now, I know it is very difficult for you to remember all of this just now, so understand why I'm discussing this because this will come in handy in exam. So after the class, just you need to go through this again, and then it will make more sense. Okay? The only other thing in hypertension is hypertensive emergencies, how to manage them. So let's discuss that. So we divide severely elevated blood pressure into different parts. So severely elevated BP without any symptom, that means patient's blood pressure is above 180 over 110. That is called severely elevated blood pressure. Then we have hypertensive urgency who has elevated BP, but also they have symptoms, but they don't have any end organ damage, which means their kidney, their retina, those are intact. And then there is hypertensive emergency, where blood pressure goes to 220 over 140. They have symptoms, they have end organ damage like hypertensive retinopathy, nephropathy, etc. Hypertensive emergency is very serious. Usually that doesn't come in exam, but you should know about hypertensive urgency and severely elevated blood pressure without any symptoms. So what will you do if a patient has severely elevated blood pressure without any symptoms? So first thing is that this patient their blood pressure needs to go down. So at least Ideally, we need to bring it down to 160 at least. Okay, so the time frame to reduce this blood pressure down to 160 is 1 to 2 days. So for a patient who has this severely elevated blood pressure without any symptom, what we can do that if the patient was not taking any regular blood pressure medication, then you can start the patient with a simple medication like ACE inhibitor, or you can start the patient with amlodipine. Those can be started. Okay, so what you do that you start a low dose medication and ask the patient to go and see their GP who can regularly manage it. So all we need to do for severely elevated BP is make sure that yes, it is actual blood pressure, it's not a white coat. And then if it is really the case, then we start the treatment, low dose amlodipine or low dose ACE inhibitor, and then we see the patient next day to see how they're doing. That is easy. What about hypertensive urgency? Urgency has symptoms like headache, dizziness, along with the elevated blood pressure. This patient needs to be sent to the hospital for further investigation. And for that patient, they will be admitted in the hospital and they will be given amlodipine or any other low dose medication to gradually lower down the blood pressure. And they will stay in hospital until their blood pressure can drop down to around like definitely below 180 or even sometimes below 160. Okay, so the only difference between treating a patient who has elevated BP above 180 over 110 without symptom and hypertensive urgency is the admission in the hospital. All right, so this group will be admitted, they will be regularly monitored and see that their blood pressure is going down steadily. For patient who has emergency, like hypertensive emergency, that's a life-threatening event, that needs to go to hospital by ambulance, and they will give them IV antihypertensive, which can be IV hydrolagin, clonidine, metoprolol, any of them. Okay? So these are all that you really need to know. Okay? So I know hypertension is not that, it's not easy. Although it looks very easy as like, oh, we know what is hypertension, but this is tricky. So knowing who to treat, how to treat is really important. Okay, did you guys understand everything? All right. So that's all that we really going to discuss for cardiology session 1 and 2 in the free session. There will be an ECG class as well, but that will be after this 2 week session is over. Okay. Yes, so definitely these are a lot of things to take in a single class. I know that. So yes, you need to make sure that you go through these again. And it's all about having a clear concept. If your concept is good, you can easily retain this information. So the first thing is that have you understood what I said? If you have, that's all that you need to do. And then when you read it next time, everything will become very clear. Dr. Kira, the schedule is already given in the Facebook. So if you go to our Facebook, you will see a lot of posts there for our next class. So if I give you our next class, so next class, today is 20th, 21st. So tomorrow there is another class. So you have another class. So there is two more class left for this 2 week session. One is tomorrow and another on 24th of June, which I feel that's Tuesday. Yeah. So those are the only two classes are left. And after that, we will start our full course in full rhythm. After cardiology, we will go to pediatrics. What is the last time for payment? There is no last time. You can enroll anytime you like, but I always suggest that do it at least this week, because in that way you will have a nice and easy, smooth journey and get access and everything. Yeah, we can do that, Dr. Rubia. No, therapeutic guideline, you will need to subscribe if you want to. You really don't need to, because there is a lot and it will just make it very hard. Something that is important, I will just discuss that how we have done, how we are doing now. And that's all you really need to do. No, you don't need to do anything else. Cardiovascular, everything that we are going to discuss, that will be enough. Yes, we will help you with those EPIC verification and AMC portfolio, but we will finish this 2 week session and then we will do those things. We have already started providing previous batch recorded class. It's already given in the portal and we are uploading more and more. Okay, so there is already a lot of previous batch recorded sessions. For 2 week sessions, this is the last class of cardio, but there will be another ECG class with after the free session. And that will be part of the course class. Okay. So it's a combination, Georgia, that you follow books and the notes like that. So there is no specific way that we say that just follow this. It's always a combination. But for cardiovascular system, there is nothing else you really need to know, because usually, like you can see that it's all covered. So if you go through the notes, go through the recordings, that will be more than enough. All right, everyone. So let's finish it here tonight. And we will catch up with you again tomorrow. Tomorrow there will be another random question solve. So that will be another mentor, Dr. Rabia. So she's been with us for a long time. It's like since I started, she's with me. So I'm sure you will also, and she's also, both of these, they are working in Australia. So they follow the same guideline that I do. So you will definitely enjoy her class as well. Okay. Thank you, everyone. Have a good night.